Okay, we're streaming now. Go ahead, Pat.
Great. Good afternoon. Lindsay, do you want to go through some of the questions that have come up?
Yes, either I or Lee will. Okay, all right, great.
Well, while you prepare yourself, with your indulgence, I'd like to raise a couple of questions that came up in the audit that just came out recently, Commissioner, and one of them is writing off the uncollectible accounts. Would you like to address that?
Yes, and if I may, Madam Chair, without objection, just to introduce the other DVA staff that are with me today is Ms. Brianna Mitchell, who is the DVA Fiscal Manager, and Mr. Matt Pawlowski, who is DVA Fiscal Admin Supervisor. And those of you who have maybe met them before, Mr. Pawlowski was with OPM prior to coming to the DVA latter part of last year. And Ms. Mitchell took over from Mr. Clark, who retired in October of last year and has been leading our fiscal office since then. So yes, with regard to, and I'm going to also ask both for Ms. Mitchell and potentially Mr. Pawlowski to address that in more detail. But over the years, there was a significant dollar amount written off by prior administrations related to uncollectibles, primarily focused on the uncollectibles of either deceased or veterans who are no longer within our facility, residential or healthcare, and under the not the concept of, but the determination that it truly was a dollar amount that could not be collected either from the estate or to locate the individual. For more detail, I'd like to ask Ms. Mitchell if she'd like to add anything to that, and of course we're available again to answer more questions on that issue. If I may, through the chair, ask Ms. Mitchell. Please, Ms. Mitchell.
Hello, everyone. Commissioner, you're spot on with that response. It's primarily from those individuals that, for lack of a better term, essentially are indigent and had really no means for making payment. Most of those uncollectibles are for those veterans that have previously passed on. So we're working here fiscally to gather up those names and then submit them for write-off request.
And if I may, Madam Chair, just one more sort of addendum to that is this goes back to an issue of where the agency at times may not have been as stringent with regard to payer source for veteran residents and veteran patients in particular. Now with the transition to a skilled nursing facility, the standing up of that license, compliance with CMS on Medicaid and Medicare, as well as our approach now is much more stringent as it relates to ensuring that the veteran has a payer source, either a Title 19, private payer, or if they're 70% or more service connected, their payment is made in full by the federal VA to the general fund. So that's the combined effort, but it is not to say that we will not have some write-offs of uncollectibles going forward.
Thank you. And I just wanted to, our Senate co-chair has joined the meeting, Senator Abrams. And I just wanted to acknowledge that she's here. We kind of barreled ahead. My apologies.
Madam Chair, you're on mute.
I have some other questions about the audit, but did anybody want to follow up on uncollectibles and writing them off? There were a couple of issues that may have been before the tenure of the people that are here. I don't know, in terms of reconciling expenditures and having receipts available. Could one of your people address that?
Yes, Madam Chair, and I believe I may have an additional staff member, our staff attorney, Jane Siegel, may be in the waiting room. I'm not sure if one of the committee support staff are able to let her in if she is waiting, but while that's happening, to answer your question, yes, either Ms. Mitchell or Mr. Pulaski can answer in more detail, but generally, again, we acknowledge that there were some of these deficiencies as cited by the auditors, and that we have taken an opportunity to create more of the proverbial paper trail, requiring managers and supervisors to substantiate purchases and to have the related receipts attached to the procurement documents. And so I'd like to ask Ms. Mitchell if you would like to address that further, and or Mr. Pulowski through the chair.
Go ahead.
So those items, I believe it was just, again, it was previous tenure, and I think it was just a lack of, people had got comfortable and maybe nothing was missing, and purchases were not made erroneously using those cards, but I think that neglecting to sign off, as other managers neglecting to sign off on individuals' purchases during the course of a month, or having to go back and chase down receipts after the fact, not turning them in. But we go back and we do find what we need to find. I think it's just us. We've tightened up on our internal controls here. We've required managers to make sure that, and supervisors to make sure that they're signing off on documents and making sure that their staff is in compliance. So we have made some measures to make sure those things happen.
And so when you say that, are you working with the state auditors to have a plan, and have you showed them what you're doing to try to remedy some of the issues?
Yes, in fact, it conducted when the auditors, Mr. Bruce Vaughn, the out-processing interview after the draft of the audit was released, and well as when they were finding these, and the initial preliminary findings were sent to us. Not only do we respond to them, we generally explain in writing what we are doing and ask for the auditor's input as to, does this address the issue, or do you have best practices to suggest to us? And very candidly, I look at the audit. They are doing their job and showing us how we can improve internal controls, that second or third set of eyes on things. So absolutely take to heart the findings. And it oftentimes though is a little difficult, because as you very well know, by the time the report comes out, the timeframes that they are covering are often 2 and 3 years ago now, and in particular some of the delays because of COVID-19. So we have met with them, and we continue to work with them to address any of those deficiencies, figure best practices to improve internal.
But I would assume some of the people who maybe didn't log the necessary information may still be in place.
Yes, you're absolutely right, Madam Chair.
Yeah.
You're absolutely right, Madam Chair. And in fact, without naming names, there is at least 2 individuals that I discuss these issues with myself, as well as with their supervisor, to improve those internal practices, particularly related to the use of the P cards and substantiating documentation at the time of the transaction, and not having to chase down after the fact, substantiating documents.
Do any of the members have any questions to follow up on any of the issues raised in the audit report? OFA, do you have any, you want us to flag some issues that came up that we may want to address?
Sure. So there were only 2 questions for follow-up. It was asked of DVA to provide a breakdown of COVID-19 relief funds, received, expended, and any amounts remaining, and then a breakdown of what the CRF expenditures were applied to. And Sukeem sent an email out on February 24th, so I wasn't sure if the commissioner just wanted to go over that email that he had sent with the information in it.
Oh, yes, the email was sent. Ms. Mitchell, I believe, was copied also to Mr. Pulowski, and transmitting that to the appropriate point of contact, which contained the answer to those 2 specific questions. If you I don't know if you're asking for myself or the staff to go through those actual dollars amounts. I believe the spreadsheets were attached to that email of 24 February that broke out those funds, including what we spent it on, what was left, which I believe was little to none at the time of the transmission, and that the total amounts in there were broken down based on relief funds, and that also is distinct, as was discussed at the committee meeting, distinct from anything that is potentially in the, then it was the upcoming America, Relief Plan Act, but now it's in place, as well as any FEMA funds that we are separately applying for, unrelated to COVID, but related to Tropical Storm Isaias. So we are working those numbers now. Are there any particular questions with regard to the actual breakdown on the spreadsheets? And Ms. Mitchell or Mr. Pulowski would be able to address those, either in this setting, or we could provide additional explanatory information by email.
What is the will of the committee? OSA, did you want to bring up one or two of the issues that may have jumped out?
I think it was fairly self-explanatory. I don't think there were any issues that resulted from the email. There's about $9,000 remaining in the provider relief fund, but the email didn't really bring up any further questions.
I guess my concern with the internal control issue was how you're making the pivot over to a new structure that we had discussed 2 years ago. It seems like a lifetime, and to make sure that a lot of that is being remedied.
Yes, Madam Chair. In fact, with the transition to skilled nursing facility from a chronic disease hospital, has required us to, as we very well should, to take a deeper dive into our internal controls, particularly in fiscal, in procurement, in tracking work hours, overtime, et cetera. And all that has been going on. As you may recall, we made that transition through 2019 into 2020 when we received final certification from CMS. We are now fully billing, I believe, and Ms. Mitchell can speak to this, and the CMS reimbursements now are going to the general fund. That we are actually a more regulated entity now as as an agency with a skilled nursing facility than we were when we were an agency with a chronic disease hospital license. So there are actually more layers of oversight by the federal government, CMS, as well as the federal VA, but also in addition to the best practices that we need to follow, that were pointed out in the audit report, which covered, I believe it was FY 18 and 19.
Do the members have any questions to follow up on the note? Well, you've navigated a difficult transition, and obviously there's a lot of concern about some of the folks in your care, in our care, who may have future substance abuse problems, and how they've responded to the pandemic, and whether they've had access to their loved ones.
Yes, so we have, just so everyone is clear, two different basic, core functions here related to our client veterans on our campus: a congregate living residential facility, as well as the skilled nursing facility. So there are distinct requirements, both internal that we put in place for COVID-19 mitigation, as well as mandates from DPH and CMS, Centers for Medicaid and Medicare Services. That being said, it has been very difficult. And as someone who has, family members in nursing care, not on our campus, we certainly appreciate that. And we've done our best to maximize visitation outdoor when the weather was not inclement. We now are back to indoor visits as well, because we have not had a positive case on campus on veteran residents, patients, or staff in 2 months. And so we have multiple regular indoor visits now in the skilled nursing facility. Veteran residents, it's a different dynamic. They leave the campus, they have their own motor vehicles, they use public transportation, so they're able to engage with, with their family and loved ones. And we are beginning next week, 22 March, Monday, to expand our visitation on campus, in particular with regard to the residential facility. But it has been difficult, not only on veteran patients and residents, but on the staff. In a 24-hour, 7-day-a-week direct care facility with COVID-19 in the community and at one time in our facility, it did create a strain. We did refer staff to the Employee Assistance Program, outside providers. We've received a lot of support from other state agencies, as well as from federal VA. So we've gotten through it day by day. And, I'll just a little plug here. If anyone goes to our Facebook page, we are featuring some of our women clinicians and commemorating International Women's History Month. And they're telling their stories about getting through the pandemic. So it is very enlightening to read that. So I know I may have gone a little off track here, Madam Chair, but I think it's important to appreciate that. And thank you for pointing that out. It's the mental as well as the physical health of our clients as well as our staff have been something impacted by the pandemic, but we are getting through it.
Sorry, I was thinking particularly of some that may have had PTSD and whether the pandemic was an additional stressor.
Absolutely. It's known as a trigger. And so isolation from your regular routine, isolation from friends and family can become a trigger. And that trigger goes back and draws out, either past memories from PTSD or something that happened afterwards as a result of suffering a TBI or PTSD, and others that are just of fragile, whether it's mental or physical health. And so we have had, our own social workers on campus intervene, some, individual intervention or group, online intervention, discussion groups in order to address that. But you're absolutely right. There's not a panacea for it. What we are noticing now with more opening of the state and us able to have more visits on campus and more travel off campus is helping some of those veterans. And finally, on that issue is the inability at times to go and have a face-to-face interaction with a therapist. That was a big learning curve or an adjustment for many of our veteran residents, particularly those of more senior in age, more the Vietnam or even the Korean War or Cold War era vets. But they have adjusted, and we are moving back with federal VA and private providers to some more in-person interaction.
Thank you. Are there other questions from committee members? No?
I have my hand.
Yeah, I'm sorry, I did not. Representative McCarty, thank you.
Thank you so much, Madam Chair, and welcome, Commissioner, and thank you for supplying all the information that we had requested. Still going through some of the audit account, but on your use of the CRF funds, and you just touched upon it now, you did use some of that to acquire laptops to do some more of the, I believe, some of the telework and the telehealth. How are you set in that regard now? And then my second part is just out of, for more knowledge on the long-term care facility. Has telehealth been used there as well? And what is the capacity right now? I think you have 125 bed, is that correct, at the facility? And where do we stand with that at this time? Thank you.
Thank you, Representative McCarty. Beginning with the last issue first, you're absolutely right. 125 bed facility in 5 different wings. One of those wings has been operated as our COVID-19 isolation and recovery unit. So those beds have been reserved for that purpose. We currently have, I believe our census today is approximately 83 veteran patients in the facility. We have capacity to receive more. We've been conducting additional outreach. I'm not sure if it was this committee, the full committee, or the Veterans Affairs Committee, but there was a question on that. And what I explained from the census was before the pandemic, we were not only we were at about 91 or 92 patients, and we were at, bringing on a new admission every week or every other week. And we were building towards our goal is about a census of right around 115 to 120, leaving a little bit of flexible beds for respite care. That being said, because of the pandemic, the natural and sad loss of veterans, not due to the pandemic, but those just because of age and other underlying conditions, as well as a hesitancy in the community to have people move to skilled nursing care, that census has been attrited down to the low 80s. We just had a new admission last week and 2 weeks prior to that an admission. So we feel that now people are getting a little more comfortable with the admission process. We do have the isolation wing. So when someone comes in, we do that protective monitoring before they're in sort of the general population, for lack of a better word, regular room. And we will be doing much more outreach, hopefully in person. We lost a lot of that because of the pandemic and had to rely on electronic means in order to do outreach, which with older veterans was not nearly as effective. With regard to the CRF and our IT platforms, yes, we have been using telehealth in the skilled nursing facility, as well as in the residential facility and in our veteran outpatient clinic, since we do have a primary care 5-day-a-week clinic in the residential facility. So in both footprints using telehealth. With regard to our IT, our laptops and computers, we are in a good place right now. I don't believe we have any major deficiencies in that. It's just a regular replacement. What we are working on, though, internally within our existing appropriations is expansion of our Wi-Fi within the residential facility. That has been needed for many years, and the pandemic really showed us that it absolutely is, because it's not just a quality of life issue and recreation issue. It is an essential thing to be able to have that connectivity. So we're expanding Wi-Fi service right now in the residential facility, taking a little while because parts are few and far between, routers and the cables. So we're working on that. And I believe, I'm sorry if I missed one other question, Madam Representative.
No, I think you answered them all, and it's good to receive that news that you're keeping ahead and trying to get the facility prepared with the appropriate broadband and Wi-Fi, because I think that is an area that we're all looking at to be sure that patients throughout our long-term care facilities are able to stay well connected with their families. So I appreciate it, and I see both chairs of Human Services and Public Health on here, so they could probably speak to that issue as well. But I certainly appreciate your response. Thank you, Commissioner.
Thank you.
Thank you, Representative. Did I understand you, Commissioner, to say that some of the older residents had difficulty with the laptops? Was it that you felt that maybe that it interfered with the therapeutic experience, or was it simply a technical issue?
There was a little bit of both, Madam Chair. And so what we would do is have someone there facilitating, whether a CNA, another clinician, to assist them both technically with telehealth, as well as to be, that human being in a room with them, again, practicing all COVID-19 mitigation protocols. But I have to tell you, I was, and continually, in awe of how well some adjust, particularly those of more advanced age. It did take a little bit, but they have adjusted. And look, even adjusting doesn't mean now this is the new normal that they want. So we do try to, again, have more interpersonal experiences to the extent that psychiatric support, mental health support can be done in person if it's required. We do that. Our federal VA, we have a psychiatrist that is provided by the federal VA pursuant to an MOU. That individual does now come to the facility and both do in-person as well as telehealth appointments. And one other item on that is we did receive, and from the community at large, a donation of a number of smart books and pads and tablets that we provided to veteran residents and patients to be able to, particularly last fall and during the winter when it was very tough, to interact with family and friends. And in fact, we did have one. It's a tough story to tell. His last conversation with his wife was over a smart device facilitated by one of our clinicians there. They at least got to see each other face to face. It was at a time when we were not allowed, and they didn't want to come into the facility, so we did it that way and facilitated it. was very cathartic for them and for the staff, but we hope to avoid that in the future if at all possible, and have in person when we can.
Thank you. Is there such a thing as window visits? And I'm trying to remember the layout there.
Yes, so we can do window visits, but it's difficult in the rooms. And so we have set up in different areas, once common areas that are not so common right now from a utilization standpoint for window visits on the first level. We also have had a canopy outside. We'll be reinstalling that for outdoor visits as well. Open on each side so there can be good circulation, but it allows people not to be either in the sun or the rain if they want to visit outside.
Thank you very much. Are there other questions from the members?
Madam Chair, could I just ask?
That's great, yes.
No, this is just a personal privilege, please. Commissioner, thank you for all your answers today. And I'm wondering, we're getting at the other end of this pandemic, hopefully, and we'll all be out and about again. And I'm wondering if you'd be open to a visit at the facility, maybe I'd love to see what we're talking about and see the long-term care facility and what you're doing up there. If you'd be open to maybe a number of us coming in.
Not only open to it, I welcome it. And I'm so happy that you brought that up, Representative. You are all welcome, whether it is in small groups or a larger group. We can figure a way to do this, or even individuals if it just simply can't work as a group. And we are, the proverbial open book. I truly love to show people what the DVA staff does and to meet our veterans, because I think there is not really, sometimes, unfortunately, not a full spectrum understanding. And it's a beautiful campus in Rocky Hill. We do great things, and I would love for you to see that. And of course, again, individually or as a group.
Well, I appreciate that, and we will be in touch. So thank you. Thank you, Madam Chair.
I think that's a good idea. I'd love to go too. I used to go all the time, usually when there was a problem. So it would be nice to be there when it's kind of serene.
If I can, Madam Chair, just throw one thing out there. We're going to actually have, hopefully in April and May, some events, including a ribbon cutting. We are coming to the final stages of an ADA upgrade project, new smoke alarms and sprinkler system, as well as repainting and doing upgrades to the residential wings. The bulk of this is either matching federal dollars, leveraging some state bonding money, as well as through in-kind, in-house work and donations. So we have not had to ask for additional appropriations. We'd love for you to see that and to potentially be a part of these events. So we'll get that information out to you as well.
That's great. And I think we've come to the end of our time, unless anyone has other questions. Thank you very much.
Thank you. Thank you all for your service and your support of our veterans.
Thank you, Commissioner. Thank you.
Thank you, Commissioner.
The Divas team is in.
Hi, everyone.
Good morning, or good afternoon.
Good afternoon.
Good afternoon, Commissioner.
Hi, good afternoon.
Do we want to start with all of the 24-page that I have? A printout of the responses to the questions?
Yes, can definitely do that if that would be helpful. I know we often will go through each one, and so happy to do that if that's helpful. So, okay, shall I start?
Absolutely, yeah.
Okay.
Yes.
Okay, so so you have the packets. So the first question, we were asked to list the federal funds related to COVID-19, to list the amounts and then also what the funds are being utilized for. And in the table, that's what we have listed. So the first part, the top part of the table lists the 4 different major funding awards we've received. So I'll go through what each of those are and then what we use the funds for. So the first one is the CRF grant, so Coronavirus Release Funds. We got in total $16 million there. 11.3 million was used for our private nonprofit providers. It funded things, many of the needs of our residential providers in particular. So things like staffing support, PPE, testing supplies or testing, cleaning supplies, temporary workers in some instances. The residential PMP providers in some instances were short-staffed at times, and so they used the dollars to fund temporary workers as well. And then 4.3 million of that went to DEMIS state facilities. For that, we funded things like temporary housing. At times we had individuals that were exposed, on the units or through their work. And so we were able to provide temporary housing for them. We also used the dollars to pay for cleaning supplies, things like plexiglass in some instances, telework technology. We expanded the network capacity and the server capacity to be able to increase our ability to provide telehealth services across the system. And so that certainly was a priority. So those are just some of the things that we funded through the $15.6 million for the coronavirus relief funds. We also received dollars, and it's a lot, so I'll go through it quickly, but we also received a total of 4.8 million. That was a SAMHSA grant that we received early on. Initially it was 2 million, and then they went ahead and they expanded those dollars and gave us an additional 2.8 million. The overall goal of that grant was to improve the health outcomes, mental health outcomes of individuals that were impacted by COVID. We paid for things like telehealth equipment, both at DEMIS and Department of Corrections. We wanted to be able to continue our collaborative work there. We also enhanced our mobile crisis teams. That was an important priority because we wanted to be able to connect with individuals that either were in hotels or at the community level that might be struggling. And so our mobile crisis teams have remained quite active. We also helped to expand 211, the 211 call center, and funded additional staff through 211. And so that was a real critical area of work. In our collaboration with 211, they often reported and still that they have received just such an increase in calls across the board, not just for mental health services and information, but for other areas as well. And
Commissioner,
DCF.
Commissioner, as you move on to number 3, and maybe I shouldn't have asked you to do everything, but there are a lot of questions here. Could you hold the thought about the mobile crisis teams, because they were very high interest at the public hearing, and I think we may want to drill down into that a little.
Yeah.
Maybe we could move on to the youth vaping question number 2.
Okay, yep, so we'll go to question number 2. And I do also want to introduce other team members that are here real quick. So I have Deputy Commissioner Nancy Navarrete, my Fiscal Director, Stephen DePietro, Legislative Liaison, Government Affairs Director, Mary Kate Mason, and I believe Cheryl Aurora may be on as well. So I did want to note that my team is here as well. Team extraordinaire is here as well. So, okay, so then the next question was to identify the staff and funds that we have and that we use for our vaping work and initiative. So there's two major pots of money there that we utilize. So there's one, our SINAR grant. That's what you see in the top table. So that is about $622,000. That pays for a supervising special investigator, a special investigator, and 2 career trainees. Essentially, through that initiative, we go into retailers and we work with retailers to make sure that they have the appropriate signage, to make sure that they're not selling to minors. We provide training and education if there are instances, unfortunately, where they are selling to minors. We have a similar contract through FDA for 1.3 million, 1.36 million, very similar initiative. And it provides additional staff to do the tobacco, the tobacco oversight work with the retailers, their compliance work really with the retailers. So that's what we have on the tobacco side.
Why don't we move through the questions and then leave the last half hour for the committee to ask questions? Okay.
Okay, that sounds good. So I'll go through them quickly. Do you want me to
having specific questions after each one? Yeah.
Okay. Okay. So we'll go through all of them and have questions at the end then? Okay. So the next.
Yeah, if that's the will of the committee.
Okay. So question 3, we were asked to explain the difference between the requested budget and the amounts that were recommended by the governor in particular counts. So for Connecticut Mental Health Center, for our BHRP program, that's our Behavioral Health Recovery Program, for Young Adult Services, Discharge and Diversion, and also Forensic Services. So I'll go through each of those. The tables that we provided go through those differences for the fiscal year 2022 budget, as well as the fiscal year 2023 budget. Many of the differences are similar, but I'll start with the first table. So for Connecticut Mental Health Center, the variance between what was requested and what was recommended by the governor is about $500,000. Essentially what occurs there is the services are maintained, and what is not included in the governor's budget is the increases. So the recommended increases for salary and for salary and raises, that sort of thing. So that's what that additional 500,000 is. But otherwise, the dollars maintain current services for Connecticut Mental Health Center. So for the next one, the Behavioral Health Recovery Program, I'll just go through what the difference is between the requested and the recommended amounts in the interest of time. The difference there is $964,000. Essentially, what's driving that difference is we requested a 6% caseload growth increase. What we received is a 3% caseload growth increase. There were additional dollars that we had in there for our ASO to be able to do a specialized audit. That's $278,000. We actually believe that we can work within the appropriated or the recommended amount. Often we have lapses in that account, so we believe that we can offer the services and maintain service levels at the level that was recommended by the governor. We can find other dollars to pay for the ASO audit, so the $278,000 approximately. So in other words, we believe that we can work within, I believe I can work within the 3% increase as opposed to the 6% increase. And that's the primary difference between what was requested and what the governor recommended. For Young Adult Services, the difference is about 1.65 million. Between the two, the requested versus recommended. And the primary difference is caseload growth. We asked for 1.65 million to be able to pay for services and supports for 15 new clients. And that caseload growth was not included within the governor's budget, recommended budget. I do see a hand up. I can take a question or
we had talked about holding questions to the end, but
I'm sorry. I thought we were asking questions if we had questions on a specific line item. I'll hold my question.
Yeah, well, this may take longer than, I was hoping that we could do the presentation by 3. and then the committee could ask questions.
Okay, you know what? So I'll go even higher level. I won't go through each one, but I'll explain what's in the tables. I think that might be even quicker. So essentially, what this table does is it outlines the differences between what was recommended versus what was requested, and for each of the programs that there was interest in, we really in detail listed out what those differences are. By and large, in many instances, we'll be able to maintain service and program levels. So let's go to question 4 then. Question 4 asked if the grant funding is sufficient to support the demand for outreach and treatment. I think one thing that helps us within Connecticut, and in some instances different from other states, is that we have state dollars and we have block grant dollars, and we do really well with the federal dollars, the competitor grants for which we apply. That allows us and has allowed us over the years to develop a robust system of services and supports across both mental health and addictions. So, our services are paid for by our grant dollars, but then also our federal dollars, so state dollars as well as federal dollars. And then there are many levels of care that Medicaid reimburses for those services and supports as well. So I think that has helped, help with our developing a robust set of services and supports. So the next question got at our vacancies. There was a discussion in our budget meeting about just the number of vacancies, where they fall within different types of positions and what some of the challenges we have with recruiting different positions. So what we provided, the first table is a list of our vacancies by job classification. So we really provide a detailed outline of where there are vacancies, and you'll see there are some areas that are more salient than others in terms of there being vacancies. So social workers, nurses, some of our head nurse positions, those are areas where we have vacancies. The next table gets at some of the positions that are the most difficult to recruit for. And so what we did was we list the various positions, and then we listed specific reasons why and some of the challenges we encounter in recruiting for those positions. So for example, physicians, and we've talked about this a few times, that our salaries are sometimes not comparable with out-of-state salaries, for example. Also, EHR is emerging. Our electronic medical record and not having an electronic health record is emerging as one of those, as a challenge that's impacting our recruitment. Physicians are often saying that and others, that to work in a system without one would be difficult because it means handwriting and sort of doing things in a way that's not as efficient. For psychiatrists, same thing. The EHR, lack of EHR comes up there as well as one of the challenges and barriers to recruitment. Salary, of course, is a challenge, and then the fact that there is a shortage of psychiatrists across the country. So we see that there. Nurses, same thing. For nurses, the charting in terms of medications, in terms of the individual or daily treatment plans, to have an electronic medical record there as well. That's something that comes up as a barrier. But then also same thing, salary. So a lot of the same reasons come up across categories that create some of the challenges related to recruiting. The next table, I do have to give my team who put this together kudos, because it was even a surprise to me to see some of the comparisons, across so many different states. But a challenge for us sometimes is the salary piece. And when we look at, for example, if we just take the top category, physician salaries, the minimum and maximum range, so 196,000 is minimum to 236,000 as the maximum within the state salary range. When we compare it to non-state business, the maximum could be 367,000 or in Connecticut, 198,000. So it's a big difference, and you'll see some of the differences in some of the other job classifications as well. Okay, so question 6, the next table gets at our, just the overall number of vacancies. So the vacancy trend over time. It has sort of waxed and waned, but we're currently at 368 vacancies. We're actively working with HR to recruit and fill those vacancies. That's been an ongoing area of work and challenge, as you can see, over the last several years. Okay. Question 7, there was a question about telehealth, and to discuss telehealth and what we're sort of thinking about in that regard moving forward. For many individuals, I would say across both our state operated and our private nonprofit system, telehealth has really helped people to stay connected to their providers. In many instances, people are able to participate in groups, so to connect with other service users, but also to connect with their providers on a regular basis. So it's something that our providers are actually advocating for us, that it continue, and that me, in my role, I'm advocating in some of the national meetings that some of the restrictions related to telehealth, that they remain, or that they remain sort of lifted. That is, that there is more flexibility around telehealth use. Of course, we know telehealth is not for everybody, and so what I see moving forward is a hybrid. It'd be nice to be able to give people the option to use telehealth, but of course, there may need to be some in-person meetings as well, and in-person contacts as well, just to be able to lay eyes and sort of have some in-person contacts and assessments with individuals. There are challenges, of course, with telehealth in terms of access. That remains a challenge across the state and country. Sort of diverse, marginalized communities sometimes struggle with accessing telehealth equipment. I think that's an ongoing area of growth for certainly in terms of our system and across the country. Next question gets at, so question 8, it gets at some of the funds for that we've used and that we've been able to secure related to the opioid crisis. What we listed there is 4 of the recent fairly large awards that we've gotten over the years. So the first one is the SPIF grant. That is our prevention framework. Actually, it's not the SPIF. The print is a little small. Sorry about that. So it's essentially a prevention grant. The next one is a grant that gets at medication-assisted treatment and in enhancing access to medication-assisted treatment across the country, or across the state rather. Another large grant that we got is the Connecticut Targeted Response Grant, so the STR. That was our first big opioid grant that we got. And then more recently, the SOR, so State Opioid Response Grant. The total in terms of what we've received over the years is about 58 58.2 million. And so, many of those programs address areas of prevention, treatment, and recovery. And so that is, and criminal justice in terms of the opioid work. And so that's an area of ongoing focus and priority as well. So things like increasing access to Narcan. We currently have recovery coaches in 20 emergency departments. We currently have a mobile MAT. So we have 5 vans that are able to provide medication-assisted treatment at the community level. And move into community spaces where people may not access services. We also have street psychiatry, so bringing psychiatrists and providers directly to community members. So a range of initiatives there to address the opioid crisis. The next table, question 9, I see I have 8 minutes, so we're getting there. Question 9 gets at just the range of prevention services and supports that we have in place. We have a really strong, I can say prevention unit and division. They've gotten really good at cranking out grants, and thankfully they get most of the grants that they apply for. And those federal funds have really been so important for us. So we have, of course, fund our local prevention councils. They do really important work with raising awareness, within schools and at the community level related to tobacco and other substances. We have the Courage to Speak Foundation, for example. They do quite a bit of education and training within schools. Connecticut Clearinghouse is another really valuable resource that just has a range of materials and resources related to substances. And so you see the other programs that are prevention focused as well. The total dollars is $1.98 million that we have for our prevention services and supports. On question 10, similar to one of the other questions, but I asked about the FMAP program. Essentially, DEMIS is gross funded, which means that all of our dollars and funds are given upfront, and then we do billing retrospectively. And so that often is how the funds are managed in terms of the services and supports. And then, of course, we have many agencies bill Medicaid as well for services. Okay. So the next question, question 11, it gets at, okay, identify where there are access issues. Where in the state is there a lack of services geographically, for example, the Northwest services, and how regional pay impacts this. What we did with this program or this particular response is we wanted to provide a graphical representation of where clients, where clients are regionally in terms of our PMP providers, and how that maps onto or how that compares to the resources that are provided within those regions. You'll see there's a pretty tight correlation between where there are lower numbers of clients, or for example, in region 2 or region 3, versus higher number of clients. So the areas where there are fewer clients, there's slightly less resources, but the resources that are there are able to provide, does provide a range of services and supports to match the clients that are in that area. In some instances, we know all levels of care are not provided in all areas. So in some instances, of course, people will have to travel for detox. We don't have a detox in every region of the state. A few states do. It's not necessarily an efficient way to run that level of care. However, at any given time, we often do have beds available, and our real-time bed availability website often maps that out. So really over the next 2 pages, that's what the graphs show, where the funds are relative to where the clients are receiving services. Okay, so the next question, question 12, asks for resources, the resources that are provided for our mobile crisis services and supports. And what we did is we outlined the top table provides the resources for each of the mobile crisis teams, both on the private nonprofit and the state operated side. And then the bottom part of the page lists out the services or the resources that are available for essentially crisis respite services. So you'll see the dollars that are there. We have gotten quite a bit of additional resources as a function of the COVID dollars, and you'll see how it's broken out according to general funds, block grant funds, and then the COVID funds. The final column is the total dollars for crisis expenditures, and it's at $19.3 million for our crisis services and supports. Okay, so question 13, the military support program. So the military support program, the total dollars that go that fund that program is $326,000. And so essentially what that funds is one full-time community clinician, as well as one full-time community specialist. And then we also have 20 clinicians that are embedded within the various National Guard units around the state to be able to provide services and supports. Some of the areas that are addressed through the program are things like bereavement, financial counseling, legal, medical, health, anxiety and depression, marital So really the full range of behavioral health challenges that the Guards individuals may be experiencing. So that's the MSP program. And then the last question asks about the funding for the regional behavioral health action organizations. And so we list out the FY20 funding as well as the estimated expenditures for FY 2021 and the overall resources are listed there. So you'll see that they're funded through a number of different resources to include block grant, mental health block grant, substance abuse block grant. There's some pre-trial resources that fund the RBHOs, as well as our federal opioid dollars also fund quite a bit of their work. They've been very active with the federal dollars with helping to provide Narcan training and dissemination across the state. So that's been a really valuable partnership for us. Their overall funding is estimated at about $1.56 million. So I'll stop there with 2 minutes to spare before 3 o'clock.
Thank you. Thank you. I realized I gave you, I have a bunch of questions, but Representative, did you want to, was there something that you had specific to a previous section?
Mine is just, I have 2 questions that I was going to ask in this session, but you can ask the chairs of the committees first. Mine were on the wonderful explanations that the commissioner gave. I was very impressed with your details, but I can hold unless you want me to go now.
Well, but I want to raise a couple of questions that we didn't quite go into, but I don't think it'll take too long. But the Commissioner, thank you very much for all the detail you provided us.
You're welcome.
As you probably noticed, there was I think there were 204 people signed up for the public hearing, which lasted after midnight. So there's high interest, and there was and a lot of concern about the strength of the system. So
I watched it. It's always so powerful, and I appreciate people sharing their experiences related to our system.
There you go. And thank you very much for the work that you did during this pandemic. I know that you became ill yourself, but the question that I started to raise about the mobile crisis, that I know there were multiple questions from legislators about mobile crisis, and what we neglected to ask was about where it was 24/7 and where it was not. And I was, for example, the region where I live, it would be technically 24/7, but I think there's basically one social worker out of CMHC until 5, and then after 5, it's a phone call. Is that true?
Yeah, so the hours do vary across the board. Certainly if somebody is in crisis and they call the line, especially now that we have the centralized call line. So now what we've done is we have the action line through 211. What we wanted to do with the action line essentially was to be able to increase access. So now it's 24 hours a day, 7 days a week, 365 days a year, that a person can call the action line and be triaged to the most appropriate sort of level of care or service. There are some hours, depending upon the hours, in some instances, they may be connected directly to a mobile team. In other instances, depending upon the emergency, they may not yet be connected directly to a mobile team. 211 will triage them elsewhere. And so it sort of varies based on the individual and based on what they're experiencing. Yeah.
Thank you. And I did hear a lot of anxiety about Hartford, but I also wonder about Eastern Connecticut and the Quiet Corner and whether or not they have access. So I just we'll probably discuss that later. And I wanted to ask about the nurses. Does that at any point threaten our accreditation?
In terms of our accreditation, it's something no, I mean, that hasn't come up as an issue. We'll often, we bring on temporary nurses, and we make sure that for every shift, we're appropriately staffed based on the acuity of the individuals on the unit at the time. Where the challenges do come in is sometimes we do have to, if we're short-staffed, it does mean that we might have to mandate individuals. And so in some instances, staff, are being mandated to provide services because per our, I guess, accreditation, if you will, or licensing regulations, we do need to have a certain, at least at the hospital, at CVH, we do need to have a certain, staffing patterns and requirements. And so we always staff to what those requirements are as much as possible. And so in some instances, people may have to work overtime.
Thank you. And on the opioid, we had some very powerful testimony from the Office of the Medical Examiner about overdoses, and I was just concerned about whether or not, we have wait lists in our existing treatment facilities, and whether or not we're really doing enough to reach out to people.
Yeah.
It's an important question. It's a criticism of you.
Yeah, I appreciate that question. I think that outreach and engagement is something that we're grappling with on an ongoing basis, and really does drive many of the, certainly even some of the recent funding decisions. Increasingly we wanted to be able to provide, services on demand. We know for opioids, not everybody necessarily needs a bed. For some individuals, if we're able to start them on medication-assisted treatment, that it helps them manage their cravings so that they can continue with their daily lives. So one of the goals has been to increase access to medication-assisted treatment, and as a function of that, we have funded 5 mobile vans around the state. So we have a van that goes around the Hartford region, New Haven, Milford, and Bridgeport, Torrington. There's probably one other that I'm not thinking of right now. I don't know, Nancy or Mary Kate, but the goal is to make sure that the services are accessible. And then, so there are a range of services and supports that we offer, again, in the areas of prevention, treatment, recovery. We also have a real-time bed availability website that lists around the state where the beds are available. And often what we find is at any given time, there are beds available at different levels of care. So there's not necessarily wait lists. Almost every time I do an opioid forum, I'll go and check the real-time bed availability website, and often just check it just to see. And there often are beds available at different levels of care. Detox often runs right up around 97, 98%, but often there are beds available. So certainly I think there are as we get additional resources, there are other areas we want to scale up and want to sort of continue expanding. So definitely have some of those interests in mind as well as we get other federal dollars.
Thank you. And there may be some issues about discharge and diversion in young adults, but I won't do that right now. Is Senator Abrams still here? Yes. Did you want, Senator, did you want to raise some issues now? No?
Sorry, I couldn't find my picture. I had to unmute. No, I'll let the others go first. They've been waiting, so go right ahead.
Great. Representative Bethan, and then Representative Abercrombie, and then Representative Betts.
Thank you very much, Madam Chair, and thank you, Commissioner, for your responses. You and your team really outdid yourselves with the amount of information you gave, so I really appreciate it. My questions are more in kind of not not what you provided, but more of some of the content. So you asked, you requested 6% case growth in slide 3, or sorry, response 3, in a few line areas, and you received 3%. And two questions. Wanted to find out, you know, I mean, all I'm hearing from the advocates is their concern over mental health issues, addiction issues, particularly in light of COVID, times of isolation. You know, people struggle. We know, we hear it, we see it, we read it in the papers. And I guess my concern is, you know, are we being realistic by only guessing a 3% growth there? And is there an opportunity for the agency to get some COVID dollars to help support additional caseload growth if we need some, particularly in light of everything that all of our residents in the state have gone through? That's my first question.
Yeah. No, thank you for that question, Representative. You know, I mean, often when we put together our, requests, we're certainly looking forward in terms of, what may be needed. We'll put, additional resources in there trying to project out what might be possible. For this particular line, often we have lapses in it. So what I mean by that, are there additional resources that may go unspent within this account? And then we also have an area that we included, the 178,000 that was part of our request that we can look for funding, elsewhere in one of our other accounts to be able to pay for that. That was resources that was going to go for our ASO for a special audit. So we can dip into perhaps other expenses or another account to pay for that. And the fact that we, because we have additional resources often left over in that account, it's possible certainly that we'll be able to manage the individuals and work within that budget. Certainly we'll be paying attention to it and looking at that as the year goes on. We anticipate we'll be getting additional block grant dollars through the American Recovery Act. And so that certainly can help with our service system, both on the mental health and the addiction side. And we're hearing that there may be additional opioid dollars coming down the pike as well. So we're always paying attention to some of those federal resources that are out there, because in many ways our system is comprised of both are funded by state dollars as well as what we get in terms of federal dollars.
Yeah, I heard you when you said there's lapses in the past, but this is the first 100-year pandemic that our state's been through in 100 years. So we're talking modern budgeting here. And, I do wonder, again, when we talk about lapses, we have agencies that are screaming for more and that they need it and people need the services. So I always get concerned when I hear there's lapse, especially in these areas. My second question really has to do on the opioid chart that you had on slide, the federal funding, question 8. There was a few areas where the feds haven't provided funding in, like the Connecticut MAT for medication treatment, other targeted response. The funding has diminished in those areas. Can you respond why we haven't received additional federal funding in those areas in the last few years?
Yeah, so there are instances where federal awards will end. They'll sometimes end the award and change the name of it, or sort of sort of reconceptualize the award. In many ways, I would say that's what happened with the STR, so the State Targeted Response Grant, and then the State Opioid Response Grant, so the last two. And you'll see when they ended, when STR ended, SOR began. And so many of the initiatives that we funded with STR, we were able to pick up with SOR. So that was what occurred with those two. Essentially, it was still funding much of our opioid work. And so that was the case with those two. I believe MADEX ended as well. MADEX was a grant that the award term on it was until August 31st, 2019. And so, so sometimes when we get the award, it's often for 3, sometimes 5 years. And so it's just based on the federal term.
Okay, well, thank you. Yeah, the account that slide looks a little volatile with the amounts kind of going up and down. So thank you for that explanation. And I just wanted to say thank you for Mary Kate. Yesterday was great it was yesterday, going through some of the questions that I've had on the governor's proposal legalization and what is going on within DEMAS. And I'm looking forward to getting a better picture, because I really want to make sure that the state is committed to helping with any addiction issues that we have as a result of legalization. So thank you in advance for your help there. And thank you, Madam Chair, for your help.
Thank you, Representative Abercrombie. And then Representative Betts.
Thank you, Madam Chair. Good afternoon, Commissioner. It's great to see you.
Yeah,
I apologize
good to see you.
that I wasn't in the first hearing, so if some of my questions overlap that, I apologize. What's the total in lapsed dollars in your agency for this year?
The total in lapsed dollars? I do not have that with me. Stephen, do you have that by chance?
Lapse dollars, basically the lapse that we're going to be projecting, that we have been projecting it with OPM, is mainly in our personal services account and a little bit in the home and communities waiver account. And we're going to be using those dollars to FAC to fix other shortfalls in a few of our other accounts, like the discharge account, our other expense account, and our professional services account, where for our docs, because we've been using a lot of contracted docs. So we'll be using those lapse dollars to offset those shortfalls.
How much, Stephen?
I think we're looking at, as far as the overall.
Yep.
I want to say 10 million.
So 10 million in, so let me.
So it's 10 million in the personal services line and 800,000 in the home and communities waiver line, because of, with COVID, it's been very difficult to get all the discharges that we were anticipating for this year.
So let me just repeat what I think you just said, and I want to make sure we're on the same page and there's no confusion. So 10 million from the personal service line item, and you're using all of that back in the agency to backfill some of the services or increases to some of the providers. Is that correct?
It's to cover shortfalls in the discharge account. That we didn't get all of our discharge money because of last year with the, because it was supposed to be funded through deficiency. We didn't get all those last year. So we're going to use it for that. And we're going to use it for our shortfall in professional services or for our docs. And we're also going to be using it for our OE account, because our OE account, which is other expense account, that's where we've been paying for screeners, increased cleaning, when we had COVID units, getting the units ready for COVID and those types of items. So that really increased our shortfalls in those accounts. So we're going to be using those lapses because of basically the PS account is lower this year than anticipated. Part of it is our overtime is better than it was in the past. And the vacancies, just trying to get people hired. It's been very difficult this year.
Well, I think part of your challenge is your rates are lower than compared to other states.
Exactly.
And I'm surprised that there isn't any increase in this budget to address that. So I'm concerned about that also, because especially the area that you're in, it's not like you can go out and get a lower level clinician for some of this work that has to be done. So I'll say it again, I'm surprised you guys didn't ask for more, because there are dollars out there. So I guess we'll have to do it for you. Second question is on the personal services to professional services. There's a $1 million transfer. So how does that equate to the 10 million in the lapsed dollars? Why is that particular line item identified differently?
Yeah. So the professional services are often the docs that we need to bring in on a temporary, for a temporary basis while we're looking to hire. So it may be docs, it may be nurses or other temporary staff. So it's any of the professional services that we need to contract. We'll often contract with either outside vendors for those, in many instances, while we're looking to recruit other staff.
So can we get a
Permanent
breakdown of
staff.
that, ma'am? Can we get a breakdown, Commissioner, of that? Because $1 million, I'd like to see how many and how many hours they performed. I think that might be helpful on that particular one.
Okay.
And then just finally, the COVID dollars under the American Relief, are you qualified for any of those dollars? Have any of them been,
Yes.
and how much is that?
Yeah. So, and this goes to the question earlier. So we are expecting additional COVID dollars there. So for example, we'll be getting 17 million, approximately 17 million in substance abuse block grant money. And then, some of that will go towards prevention services and supports, others towards treatment, recovery, training. And then we'll also be getting an additional 8 million in mental health block grant resources. Again, there's a set aside, so 30% of that will go to DCF, because we often give DCF 30% of our mental health block grant. And the remaining 70%, or 5.6 million, will be for DMIS services and supports. So to Representative Den's point earlier, there are many, absolutely, we're seeing the ripple effects of COVID increase across the board, increases in sort of mental health challenges and addiction challenges. And so some of these COVID dollars will absolutely be helpful in terms of our state and other dollars to be able to provide additional services and supports across our service system.
So let me just ask you if you could clarify. So for the 17 million and the 8 million, am I understanding that those come through already existing grants? Or are you saying that under the COVID American Relief, yours come through as a separate grant?
So ours is going to come through as part of our block grant. It'll be a separate block grant allocation, a two-year allocation that will occur over 2 years for the block grant.
And is that broken down in this budget someplace in these sheets? And I apologize if it is, because I wasn't here at the first meeting, but did you identify how you plan on using those dollars in the future?
No, because we only just learned of that award, and our plan for what we plan to put in place related to that is due April 5th. So those dollars, this is new. It's not included in any of those tables. It's a function of the American Recovery or Rescue Act that just passed.
So it would be helpful, Commissioner, if you could identify how those dollars are going to be used, because then some of these cuts that are in this budget could be put back in through those dollars so that we don't have to take state dollars offline. So if you could, and I know your staff's probably working really fast and hard on that, but the sooner we get that, it'll help us in our decision-making for this, for your agency. So thank you. Thank you, Madam Chair.
You're welcome.
Thank you, Representative. Representative Batts.
Thank you, Madam Chair, and thank you, Commissioner, and certainly to your staff for all the specific information you've provided. It's very helpful. I do have a couple of questions. One is, do you have a relationship with Prudence Crandall?
Prudence Crandall.
They're in New Britain. They're based in New Britain on domestic abuse and substance abuse. And they just had an article in the paper saying, primarily because of the COVID, that there had been a 250% increase their normal workload. And they've actually had to put people up in hotels just to keep the parent and the child safe. And obviously it's related also to substance abuse as well. But I didn't know if you had a relationship with them, because clearly that's an area that has escalated to a very alarming rate. They've asked people in the private sector to give money and they've responded. But I mean, I think it's really a shock to many people to see how much has been going on without anybody really knowing in the public.
Yeah. Yeah, I appreciate that question. So that is one of the areas where we've invested some of our federal dollars as well. But we've worked through CCADV, so the Connecticut Coalition Against Domestic Violence. Essentially what we did there is we funded additional staff so that they could scale up their lethality assessment teams. The lethality assessment teams are teams that are able to, they're on site, they do assessments, they work closely with officers. And they're able to connect women to services and supports. If in instances where the assessment identifies that there's a possibility of additional domestic violence. So we've given through both 2 different federal awards, we've been able to increase some of the resources that go to CCADV. And they very well they may work with the organization that you mentioned.
Yep.
Yeah.
Okay. Well, thank you, and I'll kind of keep you posted on that, because I do foresee that continuing to grow, and to be able to provide services and treatment is going to be multi-months, because they are very, very intense and very serious problems. The second one, I am a little surprised, and maybe I'm misunderstanding it, because we had a very lengthy hearing yesterday in public health, listening to people talking about the difficulty with access, the lack of ability to make payments, the growing need to get counseling, but it gets interrupted. And I'm sort of, by word of mouth and stories, anecdotally, hearing a lot of people saying, well, kids are having trouble going to school. A lot of people, all ages, are having trouble coming out of their house. They're having anxiety attacks and isolation and depression. So I'm wondering if you and your fellow commissioners are working on putting together a master plan on how to respond to what is going to be very predictable here. And one of the ways I would think you would need to respond is you need a lot more psychiatrists. I mean, it's very clear to me, looking at that sheet where the comparison was of the salaries, we're not even competitive. And I would not be shy in pointing that fact out, because they play a very significant role. And if you're not able to get psychiatrists, it's just going to increase what I think is an overstressed system right now. And is there anything that we can do to help you in terms of the recruiting of psychiatrists, much like we did with the Office of the Medical Examiner?
Yeah. I mean, I think certainly with the child psychiatrists, I mean, it's challenging even on the adult side. On the child side, it's even more challenging because of the national shortage, unfortunately, of child psychiatrists. One thing that's on the national level that's a best practice is thinking about pipeline programs. So are there ways in which we can start younger and outreach, individuals that are in high school or college or even younger, and increase their awareness and interest in the behavioral health field, and in particular in psychiatry. That's a long range. It's not a short term, it's not a short term intervention. So it is a challenge in terms of bringing in additional child psychiatrists. We struggle with the psychiatrists to work with adults. And so that's something that we're working on an ongoing basis. We have, with some of our funds, we have funded DCF in terms of some of the programs that they're implementing to take a family approach to working with young people that may be struggling. So there is, quite a bit of collaboration there between DEMIS and DCF.
And I know that's been very good, and that's very heartwarming and uplifting and very important. And that's really what I'm looking for, is more collaboration. That I'm looking for, but what I think what the system really needs. And, I know adults don't sound as urgent as you're doing it with kids, but there are a tremendous amount of adults who are just struggling with situations they've never had before. And again, I know you talked about 211 and people being on 24/7. My sense is, in listening to what's been going on in public health, I really think there needs to be more support and resources devoted, because I think it's a much bigger issue than what we're seeing here on paper. So I just wanted to urge you to really think about that, not so much in a, because whatever you do is going to be long-term. There's not going to be, 1 or 2, 3 months. What I'm worried about is you get some federal money under the federal rescue plan, and all of a sudden, after you invest 2 years worth of that, and the program's really beginning to meet the needs, it suddenly evaporates.
Thank you, Representative. Representative Sims and Representative McCarty, or I just turned you into a McCarthy, I'm sorry. Representative Sims has been very patient here. So thank you very much, Representative Betts.
Thank you, Madam Chair, and thank you, Commissioner, and your staff for the great work that you guys are all doing. It's greatly appreciated. I have just a quick question. I noticed while looking at the work group question, and I on page 12, I noticed that Norwalk wasn't included in any of the allocated budget. Is there a reason why Norwalk isn't included in those budgets, or with regards to the mobile emergency crisis services?
So Norwalk, so this is on page 12. Our mobile teams do cover all regions of the state. It may be that the team that manages Norwalk works with a couple different towns. Just looking for the page here. I don't know, Nancy or Mary Kate, while I'm looking for the specific page. I mean, I think it's
our LMHA in that area covers all the way from Bridgeport down to Stamford in that area.
Yeah,
our southwest location.
Okay, that was just my only question. Just want to make sure that cities like Norwalk and Stamford aren't left out, right? Because I know for a lot of the other cities, surrounding cities, they get a lot of the funding and services. So we want to make sure that Norwalk and Stamford are always being included as part of that that appropriation process. So I thank you for your response, and thank you, Madam Chair.
Thank you. And if I can add, for mobile overall, that's the approach. So every area of the state has coverage, but not every town will necessarily have its own mobile team. In many instances, a team will work several different towns. So we take a regional approach to make sure that we have full statewide coverage.
Well, thank you again for that explanation. Appreciate it.
Thank you, Representative. But we have been hearing a lot from the public and from advocates that what looks like coverage sometimes is not adequate. And I've heard it even where we live, and theoretically, there are more resources theoretically in the region where I live, and there's tremendous need, and the same goes for Hartford, but there are other areas, but that's not on you, that's on us. So I'll just leave that there. Thank you very much for raising that issue, Representative. Representative McCarty.
Thank you, Madam Chair, and I'll go very quickly. We're 1 minute over. So I just wanted to welcome the commissioner and her staff and add my voice to my colleagues that thank you very much for the detailed reports. I'm going to put it in a binder and save it So I appreciate very much that you supplied us with all that. And I would like my colleagues to know, aside from 211, the commissioner has always been tremendous and very responsive if you have an issue. And I wanted to recognize you for that, Commissioner. You really care about your department, and it's very well noted. So thank you so much. But I just have two very quick questions on the allocation of the CRF funds. I know because I'm familiar with the Department of Education and how that process works. And in DEMIS, do the providers do you receive applications for what their needs are? And does it work in that same way that it does in say, the Department of Education, where the superintendents have to actually request their particular needs? So that was number one. And then just on the vacancies piece, looking through that, it looks like you really need mental health assistance. Could you just tell me what those little numbers 1 and 2 mean on those vacancy chart? For instance, it says you need 33 mental health assistants, but then you have 2 categories there, it looks like. Just what that's about. And then I'm just really pleased to hear there'll be more funding for the other SBAG grants coming in. So we'll talk about that, but just that very quick clarification. Thank you.
No. Thank you for the question and for your kind words as well. So I appreciate that. And I look forward to, I know when we're in person, we often are on the same forums or many of the events, the essay contest up in the Norwich region. I look forward to when we can do that again in person, but just put that out there.
Yeah.
So yeah, it really depends on the pot of money in terms of whether providers are asked to put together a plan. In some instances, we always ask for some plan in terms of what is the spending plan. Particularly, we need that for the contract. We need to know what the deliverables are. It helps with monitoring and oversight of the work. And so that I think is present across the board. There are some, of course, that may be, although we didn't do RFPs for this, we decided that RFPs, because everyone is so taxed right now, we didn't do an RFP process. So in some areas, for certain CRF funds, they were given a certain percentage based on, what their needs were, if they had specific requests there. So CRF was based on a percentage. There are other buckets. For example, for the coach initiative, for that we hired 37 crisis counselors across the state. The crisis counselors, in terms of their work, that was already outlined based on the parameters or the goals of the grant. So that was pretty straightforward. But the teams that were funded to do that work, so we connected with faith communities in some instances, or some of our other community providers to do that crisis counseling and outreach work. In those instances, it was a different plan, if you will. It's but based on the parameters of the overall grant, if that makes sense. So they weren't proposing sort of, what their, how they're going to implement it, because that was already dictated by, in many ways, by the grant. But we still wanted some plan of what that would look like, what their program would look like within the parameters of the grant, if that makes sense.
Right. Thank you. Yes, it does. Oh, thank you.
Okay.
And then on the medical assistant, what are those 1 and 2s? What does that mean?
Yeah, so it's the different level of mental health assistance. So there are different types of mental health assistant positions. So the mental health assistant 1 or mental health assistant 2, it just speaks to what their specific role is, and it's essentially a job classification difference.
They're all mental health.
One's more senior. So the mental health assistant 2 would be more senior than the mental health assistant 1.
Okay, and is that, because that looks like quite a need if you go through the numbers, and is that typical, do you think, or has that increased? Because I think there should probably be more and more need for mental health assistance right now to take some of the work off of the psychiatrist and the doctor. So
Yeah, I mean, you'll see the vacancies have waxed and waned. There was one year, I think this year it's 368. Last year it was a bit more than that. We are often in a cycle of recruiting mental health assistants, 1 and 2s, forensic treatment specialists, the nurses, so head nurses, as well as the docs, and it's a constant, if you will, cycle of recruiting staff. So staff will often move around. I mean, they may move from agency to agency based on salary, and so it is an ongoing thing that we're working at. We're almost always recruiting. Right now, the numbers are high though, and you're right. There are needs, in part because people may be out because they've been exposed. They may be quarantining. They may be out because they have been exposed or because of travel. So now we're definitely feeling the vacancies and the limited numbers of staff, or the down numbers of staff, that is.
Thank you, Commissioner, for your explanation and for all your work. And thank you, Madam Chair. I know I don't want to push my luck.
Thank you very much. And thank you, Commissioner, for being so thorough in your responses to us. I do worry that, especially because there were a lot of cuts under a previous administration, that the cumulative effect of not having permanent staff and then bringing in other people may affect continuity of care, or that just a lot of damage may have been done. And I don't know that your department really is getting what it needs for us to meet this moment. But we'll look over all of the information that you provided, and I do want to thank you for the work that you do.
You're welcome. You're welcome. Thank you. Appreciate being able to have the discussion and answer questions.
Thank you, Commissioner.
Okay, take care.
Bye-bye.
You're welcome.
Right.
Bye.
Thank you.
You're welcome.
Thanks. Kathy, are we finished?
I think so. I don't know.
Oh, I saw you staying. And by the way, thank you for all your work. I wanted to call you. So while you're still here, thank you so much for all your work. I don't know how, I'm still amazed by how you are everywhere and you're on top of all these big issues.
I don't know that I'm on top of everything, but I think we're getting there.
Yeah, and I hope you were happy with the model curriculum. I worked on that, and I
know.
wanted to, we are going to push it. So just so you know that.
Thanks, appreciate it.
Yeah, and thank you. I didn't know whether we're done. We have so many meetings, it's hard to tell if we're finished or not, but.
I can't tell either. People are coming on and going off. I don't know what the heck is going on.
Kathy, are we held?
I think we're all done.
Yeah. I was looking at Kathy Kennedy there too. She's still here. All right. Well, have a good day, everyone.
Bye, guys.
Hip, hip, another one done. Thanks. Bye-bye.
Bye.